Central Desk 9.6, we are going to discuss the major diagnostic category of mood disorders. I think horizontal works the best for today's concept map, though if you really like vertical, you could probably do it vertically as well. It involves the 5 total boxes that you see here, the definition of mood disorders at the top, 3 boxes from left to right on that secondary level, describing the 2 forms of depression and 1 bipolar disorder. Then we'll talk about the understanding box at the very bottom. I'll return now to the task text, allow you to pause the video before continuing into the concept map. We'll start all the way at the top and briefly describe what a mood disorder is. A mood disorder is a psychological disorder that is characterized by emotional extremes. So that could be the highest of highs, or it could be the lowest of lows. But we're talking about mood. So we're talking about depression. We're talking about bipolar disorder. We're also talking about what's called mania, an element of bipolar disorder. Transitioning now into the actual disorders themselves, there are 2 that are classified under depression, though technically we're going to refer to a third one while talking about these 2 boxes. Then we're going to talk about bipolar disorder. So first we'll talk about depression. There are a lot of depression symptoms that we look for when diagnosing, and we need to list them at least once. So it will be in this first box where we list 9 depression symptoms, and then from this point forward, if we refer to depression symptoms, these are the types of symptoms that I'm referring to. Major depressive disorder, assuming there's no drug use, that disclaimer is important, necessitates at least 5 of these systems to be present for a period of 2 or more weeks. Assuming that at least one of those 9 total symptoms, but 5 that are necessary to diagnose, come from these first 2, either a depressed mood or a loss of interest/pleasure in activities that you typically do. Assuming the patient exhibits at least one of those first 2, for the majority of the time, for at least 2 weeks, you're then going to try and diagnose based on whether or not the total list of symptoms reaches 9. Technically, the second symptom could actually just be the first 2, and then you could draw 3 from these additional 7, or again, you only need 1 from the top 2 and then 4 from that bottom list of 7. But to go through all of the depression symptoms. So of course, we had depressed mood and loss of interest in activities that you typically enjoy. So for example, if you really enjoy exercising and then you stop, you typically enjoy reading and then you stop. Those would be examples of a loss of interest in a behavior that you typically enjoy. From that point, we're looking at either fatigue or lethargic behavior. Those can be slightly different. There's a big difference between being fatigued sort of throughout the day and then sort of have this slow pacing lethargic behavior. Those are slightly different. 5 is a difficulty concentrating or making decisions. So perhaps that could be at school or at work. 6 is significant weight change that can go in either direction. You either could be eating too much or eating too little and either gain weight or lose weight. And it's important here that if that is happening, that we identify that it is a byproduct of depression and not an eating disorder itself. As is the case with every disorder, when we're diagnosing eating disorders, to go back a few essential tasks ago, we need to rule out that it could be the byproduct of a larger diagnosis, which in that case could be depression and not an eating disorder. 7 is too little or too much sleep. And again, same deal. If we're diagnosing somebody with insomnia, one of the things that we would do is make sure that the sleeping disturbances, in the case of insomnia, of not sleeping enough or having difficulty falling or staying asleep, is not actually major depressive disorder. If we're working with a patient that's exhibiting depression, we don't want to treat it like we would treat insomnia. We should treat depression, and then the sleeping disturbances would likely be alleviated by default. 8 is feeling worthless, which can be a little bit different than a depressed mood, and then 9 is suicidal thoughts. So when we diagnose major depressive disorder, we're looking for 5 of these 9. It could be more, but we're looking for 5 of the 9, assuming 1 comes from the top 2, and they need to be present the majority of the time for at least 2 weeks. So this isn't necessarily just one bad day where you exhibit some of these symptoms. It would have to be persistent, majority of the time, for a 2-week window. I should note that some individuals experience these symptoms only during certain times of the year. When the depression symptoms are present only during, for example, the winter, which is when this typically occurs, we would call it seasonal affective disorder, essentially what we call seasonal depression. So if you're familiar with that term seasonal depression, where you exhibit some of these symptoms during the winter as opposed to the summer, it is in many ways a byproduct of light in the environment changes and how much of the day is exhibiting sunlight versus darkness. And that can mess up with your circadian rhythms and some of your body regulation, to go back to what we talked about last unit. So when depression is specific to the winter, we call it seasonal affective disorder, or the fall. It doesn't necessarily have to be the winter. Zooming back out, there is a second form of depression for our purposes, and these are not technically the only 2 forms. There are more than this. There's postpartum depression, for example, as I alluded to, seasonal affective disorder. So we're going to list 2 fully, reference 1, but do acknowledge in the back of our mind that there are other forms of depression. The other one for our purposes that the College Board refers to is called persistent depressive disorder. This is a mildly depressed mood more often than not for at least 2 years. And the term mildly depressed, I want to make it clear that that doesn't necessarily mean the depressed mood doesn't rise to the level of major depressive disorder. The mildly depressed element of this means in terms of that list of 9 symptoms, we're only going to look for at least 2. So instead of hitting 9, let's say the patient hits 3 of them. Well, that's mildly depressed in comparison to that list that had to reach 5 symptoms. The key detail here that differentiates beyond the symptom number, though, is the length of time. Obviously, 2 years is quite longer than 2 months, or 2 weeks rather. It's longer than 2 months as well. But with persistent depressive disorder, we're looking at a patient who, for a course of several years, is experiencing this depressed mood and depression symptoms. What's really important to then note also is that an individual who is experiencing persistent depression could experience episodes of major depression within a larger diagnosis. So, for example, let's say between the years of 18 to 20, you were diagnosed with persistent depressive disorder. But for a couple of weeks, let's say a month here, a little bit after 18, and a month when you were 19, you just had 2 or 3 weeks where the symptoms rose up to 5 instead of 2. You could experience episodes of major depressive disorder. You could conceivably experience a month of major depressive disorder and then not experience those symptoms ever again, or for a year, or for a period of time, which if we break out into persistent depressive disorder works the same way. You could be diagnosed with persistent depressive disorder but experience episodes of major depressive disorder, and those episodes where the symptoms rise to 5 might necessitate a slightly different treatment approach. So it's important to track in the midst of a broader persistent depressive diagnosis if the symptoms do in fact rise up beyond what is considered typical. It might necessitate a slightly different, whether it's pharmaceutical approach or treatment approach in general. There are 2 mnemonics, and this helps differentiate the 2 forms of depression. And I like to preface this by saying that in a moment we're going to talk about the P in persistent, and I'm going to connect it to the word punier. I don't want that to come across as the idea that persistent depression isn't in and of itself still a significant diagnosis. It's just being used in the context of a mnemonic. So let's go to the whole mnemonic, and then I'll emphasize that again. With major depression, the word that helps differentiate these 2 is the M in major. And I think M for momentary but maximum, because that's precisely what it is. It's shorter. It only has to be 2 weeks, but it's the maximum quantity of symptoms relative to other forms of depression. Persistent depression is shorter, but it's prolonged. It takes way longer. The symptoms need to be persisting for at least 2 years. So it's prolonged, P for persistent, but it's punier, at least in terms of the raw quantity of symptoms. You say the word mildly depressed, and just that word depression, I think, warrants significant attention. I don't want you to think because I'm using words like mildly depressed or punier that I'm trying to, reduce or limit how significant we're talking in terms of symptoms. But nevertheless, for the context of the mnemonics and in the context of a broader scope here, I think those word choices are okay. Moving on to bipolar disorder. This is the only box in this category. So we have 2 boxes remaining. Bipolar disorder is different because in addition to episodes of depression, patients with bipolar disorder also experience episodes of what's called mania. If depression is that lowest of lows, depressed mood, difficulty sleeping, eating disturbances, and all of the variety of symptoms that we listed, mania, on the other hand, is the complete opposite. It's the highest of highs, overly optimistic euphoria, hyperactivity, intense happiness, and it typically lasts for at least a week, though it can certainly last much longer. Patients that experience bipolar disorder alternate between relatively prolonged episodes of depression and then relatively prolonged periods of mania. Generally speaking, we're looking at least a day, a few days, if not weeks and months in one versus the other. So you could have a patient where for the month of January, they were exhibiting the symptoms of depression. And then in February, they exhibit mania. And then they alternate back and forth between these 2 very contrasting, totally polar opposite, thus bipolar, symptoms. So we have a list of symptoms for depression and then a list of symptoms for mania, and they are as contrasting as you can get. And the patient will alternate between each of these, and they can typically last quite a few months. So it's not like you'll be depressed from 10 a.m. to 11 a.m. and then from 11 to 12 exhibit mania. It's not typically that short. This disorder involves a big shift in brain chemistry, and that shift in brain chemistry isn't as instantaneous. So the shifts that we see are actually typically much more prolonged than you might anticipate. You don't have to read this whole thing, but if you look at the yellow and pink, I've highlighted a few phrases or sentences within this. This is the description of somebody who is experiencing mania, because we've established depression, but it might be more difficult to grasp exactly what does mania mean. Well, look at some of these word choices: organized, accomplished, creative, my brain is absorbing everything, crusade for the betterment of everyone, pleasure, euphoria, elation, I want it to last forever, I don't need much sleep, I bought 6 dresses, they look great on me, maybe I'll go have an affair, now I can become a politician, I'm capable of speaking. This is about as over-the-top, optimistic, and euphoric a statement as you're going to find. This would be what it would look like if somebody was experiencing the mania aspect of bipolar disorder. It's the highest of highs, whereas the depression, of course, is the lowest of lows. As a mnemonic, when you look at the word bipolar, bi means two, polar means opposite. If you think of that visual where I had depression on one side and mania on the other, that is a good encapsulation of how to think about this. Do watch, now that we've talked about it, the clip at the very top. I think it's a great, very short clip that shows you some of the brain elements of bipolar disorder, which will be useful when we talk about how it is treated at the end of the unit. The last part is to briefly talk about understanding mood disorders. There are a few things to note broadly with characteristics, then to talk about things in our society that might warrant a discussion of pertaining to what causes depression or other mood disorders, and then some things about biology. First off, when we look at gender differences across the globe, we do see, at least in terms of diagnosed cases, depression is more prevalent in women. Now, it could be that women are more susceptible to depression. It is totally conceivable. And when you add postpartum depression into this conversation, there may be some of a byproduct of that as well. But I will say, and I think this is a very important conversation to have embedded into this discussion, but also broadly into this unit, there is a stigma regarding some of the disorders that we talk about. And unfortunately, the stigma of mental health, whether it's depression or anxiety or any of the other disorders that we talk about, eating disorders, I mean, there's a variety. The stigmas that might exist in society might hinder people from seeking treatment or seeking help when they very much should. And hopefully, and I think this has been the case recently, discussions about mental health have made it so that it's more commonplace to have these very important conversations. One of the possibilities here is that males are less likely, and this has been shown in research, are less likely to seek help from their doctors when they feel the depression symptoms. And it could be the case that men are underdiagnosed, at least relative to the diagnosis of women. Now, not to say that that would even things out. That's certainly not likely going to completely even out these numbers. There likely is some type of gender discrepancy, but it is possible that the male numbers are a little bit lower than you might anticipate, simply because males who would in fact be diagnosed with depression, checking off those symptoms for 2 weeks, if we're talking about major depression or even persistent or another form as well, never actually seek treatment. If you don't seek treatment, you're not diagnosed. And of course, that doesn't account you into the numbers. So there are differences in gender. Women are more susceptible, at least according to the numbers. If it's entirely as polarized as the visual here indicates, depending on what country you're looking at, so be it. It might be a little bit closer, though, when we add into the possibility that stigma and discussion regarding mental health is still ongoing, and maybe over time, some of that stigma can go away and the diagnosed numbers can be a little bit more evened out. The next element, though, is to talk about some things about culture. I'm going to call them socio-cultural issues. The first is to talk about depression-prone thinking. When we talk about treatments of depression later on in this unit, identifying depression-prone thinking from a therapeutic perspective, and then finding ways to fix it is going to be a key detail of an entire essential task later this unit. Depression-prone thinking is when individuals explain bad events in the most pessimistic and internal manners possible. So let's say something bad happens and you explain it in terms of it being the worst case scenario, it's going to last forever, it's going to impact everything you do, and it's your fault. Well, that is depression-prone thinking. If that is a mindset you have, whether it's mistakes at work, mistakes at school, mistakes at home, mistakes on the football field, the soccer field, the volleyball field, dance, wherever it happens to be, that thinking, if it's persistent enough and it's not just in one context and it's something you exhibit frequently, well, that type of thinking might lead to a diagnosis of depression, because obviously if you have that pessimistic attitude and you dwell on the possibility that these things could last forever and are particularly your fault, that might depress mood. And once we depress mood, then there's a series of other symptoms that we would look for. The other interesting one is learned helplessness. We find that there is a connection between learned helplessness and depression symptoms. To go back a few units ago, learned helplessness is this phenomenon where Because you've been punished in the past, you stop trying, believing that punishment is inescapable, even if you could still be successful. This was a term in our midterm. Well, if you stop giving up, whether that's in school, at work, or in any other element of life, that could in and of itself begin the process of manifesting the symptoms of depression. So we've seen learned helplessness, whether that's feeling like you can never succeed in chemistry class or another area of life, potentially as an underlying cause of eventual depression symptoms. The other side is to talk a little bit about biology. I'm just going to list genetics at this point. You should know how we study genetics. We study genetics by looking at twin tests. Well, here now that we've gotten further into this unit, I've put a bunch of disorders up here, or found a chart that has a bunch of disorders now that we know basically all of them in some capacity, at least the ones on the left. Bipolar disorder is one of the really off-the-chart ones in terms of just overall correlations. It's a little bit higher than even schizophrenia. Those two are some of the highest in terms of heritability. When we talked about anxiety the other day, we said anxiety was a little bit more moderate. So notice generalized anxiety and panic disorder, way more moderate. Major depression is also sort of in that moderate category. So when we look at mood disorders in general, bipolar is off the charts. Major depressive disorder is a little bit more moderate. The right side are more behavioral as opposed to necessarily psychological disorders, though there is anorexia nervosa, which we did talk about this unit. That one's also a little bit more on sort of the moderate to high scale. Any of the other ones we haven't really talked about in any capacity, but the ones worth noting are the ones on the left. Bipolar, right up there with schizophrenia. Major depressive disorder, a little bit more moderate. So there does in fact seem to be the case that mood disorders, whether it's bipolar or depression, do in fact run in the family. The last thing, and this might be one of the most important things we talk about today, but it is the last part of today's essential task. When we look at brain chemistry, which at the end of the day is one of the key details in understanding how these disorders are eventually treated, we find that individuals who are experiencing depression, whether that's major depression, persistent depression, or experiencing an episode of depression in a broader bipolar diagnosis, the neurotransmitter serotonin and norepinephrine are in lower levels of overall activity. Serotonin is the real key one here. Serotonin was the neurotransmitter that a few units ago we attached to overall mood. We essentially gave it the primary function of regulating your mood. Low levels of serotonin are, of course, connected with depression. We're so confident in that statement that the type of drug actually pictured below, Prozac, blocks the ability of serotonin from being reabsorbed in the reuptake process and locks serotonin in your synapses longer than would be typical. That, generally speaking, for a lot of people can boost overall mood levels. So if you're willing to use a selective serotonin reuptake inhibitor or a prescription like Prozac, it would boost serotonin levels and hopefully, as a result, boost your mood. On the flip side, when we talk about mania in a bipolar diagnosis, these neurotransmitters tend to flip. So bipolar disorder is actually a very brain chemistry-based disorder, the same as depression, honestly. And as a result, the treatment methods that we talk about, which we'll get into more at the end of the unit, really try to target these neurotransmitters and, depending on which of the ends of the spectrum we're on, certainly try and treat them accordingly.